we finish, we're gonna finish up that presentation and then we're gonna go into fungal disease. So, we're gonna go back to the workup, which is kind of where I wanted to pull everything back together again, from what we studied last week. So last week we talked about a lot, about strep, Diogenes, or group-based strep, botulism, tetanus, impetigo, MRSA. We talked bacteria, how many? Two major and what?
One.
Or? One major and two minor. Good, very good. Very good. Let us see. So we talked about three types of, we talked about some bloody diarrhea, maybe bloody, likely bloody, probably not bloody, salmonella. Do we remember what that one was? Maybe bloody. What about Shigella? Bloody, probably bloody. What about C. diff? Probably not. Good. And which drugs are high risk for C. diff?
Clindamycin,
What else?
Bactrim,
Fluoroquinolone and some cephalosporins, second and third. With infectious disease, we talked about a lot of symptoms. A lot of them are non-specific. And sometimes the diagnosis isn't easy to make. So we're gonna go all the way back. We're gonna kind of take out what we learned last week and just go back to the basics. When you think of somebody with an infection, what do you think about? What did you say? Somebody said it. What's one thing? What's probably one of the main things you're gonna symptom? Fever. Fever. Yeah, very good. All right. So fever probably is one of the most common things. What if a patient has a fever, but they don't have diarrhea? They don't have a sandpaper rash. They don't have those honey colored crusts, my favorite. Or complaints of any visual disturbances like we see in tetanus. Does that mean that they're necessarily sick if they have a fever, but none of those other things? Does every patient with a fever have an infectious disease? Right. No, because fever is a physiological response to inflammation. So you can have infectious and non-infectious illnesses present with fever. What else might you suspect in a patient with an infection? We said some really non-specific general type things. What might you think?
Fatigue.
Fatigue. Yes. Anything else? Abdominal pain, maybe. Nausea, vomiting. Head, chills, sore throat, those types of things. So for you all, when you're working these patients up, really want to get that history of present illness. What are those associated manifestations? These are the things you should be thinking about. We want a complete history and thorough exam. That is key. So when you're obtaining your history, we want to look for maybe if we can ascertain a pattern. So these are some of the things you may be asking. So we have localized symptoms, such as patients, I'm going to click through in a second. So we have localized symptoms, such as the patient that had diarrhea for 3 days. So you know that I've gotten your history with that particular symptom. You've got your non-specific symptoms that you asked about. Do you have any associated fever? Do you have any abdominal pain? Ask those things. So what are some other things in our history? Think back to your labs, your OSCEs, those types of things. What else are we going to ask?
anyone else sick?
Anybody else sick? Have you been around any sick contacts? What else? Yes, especially with infectious disease and those diarrheas, because we said a lot of those things aren't going to be in the United States, but they may be with someone who's recently traveled. Very good. What else?
Introduction of new foods.
Yes, new foods. Diet. The diet might seem silly sometimes when we ask, but it can, really play a part. What else? medication history and new medications, have you had any recent antibiotics? Let's see, what we miss. We've got localized symptoms, specific symptoms, occupations, geographic residence, travel history, sick contact, exposure history. Have you been around anything new? And are you working at like a new building? Are you building a new room onto your house? Are you around building materials? All kinds of things. Are you, what kind of exposures have you had? And I will download my copy to your Blackboard as well. Now those things, so Ebola, who has heard of Ebola? Everybody heard of Ebola? Okay, so Ebola is a virus that causes severe inflammation, and damage throughout the body. There was an outbreak back in 2013 to 2016, I believe. Is known for hemorrhagic fever, and you can see the timeline down at the bottom, how quickly this thing can progress. It can lead to organ failure and death. The epidemic that started in West Africa lasted, like I said, about 3 years. In September of 2014, the CDC diagnosed the first travel-associated case here in the United States. And that was a patient who had traveled from West Africa to Dallas, Texas. He died 8 days later. Quick, very quick. And then there was another medical worker who was hospitalized that same year in New York City. She had also been volunteering in Guinea, which you see up at the top, which is where a lot of that was, but she was able to recover. So that outbreak, I think it killed 11,000 plus people, 28,000 plus were sick. So you can see how quickly that can progress. So if you see a patient at day 7, you might think it's just a general viral or some type of infection going on, but you can see how quickly that progressed. Why important that you ask the questions, important that you get a really, really good history and a travel history. If you had any recent travel, that is not a silly question because we can answer a lot of questions for it. So our physical exam, there, I think I left a caption in your resource, but this is a photo where you can see the progression over 2 years with this cardiac implantable electronic device. So when we think about the workup, of course, we want to do a really good physical exam, but there are some areas that are perfunctorily examined. So you're basically not looking at them, or you're glancing and you're not getting a good look. And some of the areas that they find that clinicians kind of skip over is the oral cavity. Open that, okay, good, and you just keep moving. When patients may have gum, abscesses, gingivitis, they may have all kinds of things going on in their mouth. If you really just take a few seconds and take a good look, that might help you with your diagnosis. Medical devices is a big one. And if you see a patient that's brand new and you don't ask, how do you know to look for this? Patients just sick, they've got these non-specific symptoms. Got a fever, they're so tired all the time, but you never ask about a medical device. How do you know to look for that? How do you know to look at surgical incisions if you didn't ask your surgical history? So again, this is just reinforcing what you're doing in your labs, reinforcing what you're doing in your hospital labs, and to ask these questions. So what tests would you consider ordering when you're trying to work up a possible suspected infection? CDC, what else? Lactic acid?
CMP.
CMP? Blood culture? Your analysis? Yeah. Any knowledge of that?
PSR tests, sorry, for like whatever you suspect it might be, you might have a point of care test or a PCR or something.
Exactly. Good, very good. In patients with mild to moderate infection, probably don't need a full workup. If it's a low risk patient, otherwise healthy, they come in with mild flu symptoms during flu season, we need to do a full workup. you know. A lot of our diarrheal diseases are self-limited, so we probably aren't gonna do a school camp culture on everybody. I think we talked about, and Jay, patients with salmonella, that's a reportable illness, but for every one case, 30 of them go unreported because you just deal with it at home if it's mild. So you're not gonna do a full workup on everybody, but these are the things you should be thinking about so that you can, know what to order. So I will put this in Blackboard for you, like I said, but these are a variety of tests. You want to confirm that working diagnosis, so you want to rule out other causes. I mean, there are the evaluations you can order, imaging, you might want to order a chest x-ray to confirm pneumonia, CTs, MRIs, PET scans, biopsies, you might need an infectious disease consult. Like we said, patients who are less likely to have, if they're otherwise healthy and it's flu season, or it's obviously strep, those types of things, you don't need to do the full workup, but you do want to consider it in these patients, immunocompromised, patients who are doing inpatient treatment, extended treatment duration. They failed antibiotics. You've given them 2 different antibiotics and it's still not working. You need to be thinking of something else. Obviously, it's not that. Infections with public health impact. So those reportable diseases, those are patients you might want to consider a further workup. What labs would you expect to be abnormal in an infection?
White count.
White blood cell count. Leukocytosis is an increase in white blood cells, and that is often associated with lab work, but does not necessarily mean there's an infection. You can also have it with malignancies. You can have it with inflammatory conditions. You can have it with trauma. You can have increased white blood cells with drug use. So depending on the severity, you may see a variety of things. You do want to be careful for a leukomoid reaction, which is when your white blood cells are extremely high. That is something that will mimic leukemia. So be careful with high white blood cell count. You want to be thinking of all these different things. On the opposite end of the spectrum, you can have low white blood cell counts as well. There are some conditions like flu, mono, HIV, TB, malaria. Those patients sometimes have low white blood cell counts. What else would you expect to be abnormal, possibly? What are some of our inflammation markers? Yeah, very good. Okay, so I believe I put this in your resource from last week, but I'm putting it here. It's not for you to memorize. It's just for you to be able to look at different things and see how they might mimic an infection. So these are just conditions that mimic infections. Cellulitis can mimic contact dermatitis or diabetic myonecrosis. UTI might mimic the kidney stone or interstitial cystitis. So this is more of a resource. We're going to put it into practice. All right, so you have a patient with an acute onset of productive cough, pleuritic chest pain, and fever. What is this suggestive of? If you had to think of some of the basic things, cough, productive cough, pleuritic chest pain, and fever, what might you think of?
Yeah.
Pneumonia, very good. So we're thinking pneumonia. We're gonna get our work up. We're thinking about questions we're gonna ask. We're thinking about tests we're gonna order. And we've got it in our heads, probably pneumonia, more than likely. But what if the patient recently traveled to a TB endemic area? Does that change possibly how you're gonna approach this? What if they don't respond to typical antibiotics? What do you think, Kim? Could be an atypical pneumonia, possibly. Does anybody, and I know we kind of did the Jeopardy game instead of going over the slides in depth, but there was one of our STIs that has that it's in that family that produces an atypical pneumonia. Does anybody know that?
Chlamydia,
Chlamydia pneumonia, yes, very good. All right. What if they have GI symptoms or abnormal pancreatic enzymes? It could be mycoplasma, could be acute pancreatitis with respiratory involvement. What if this is their fourth lower respiratory illness in the last 6 months? Any compromised patient? What conditions are we concerned about? HIV. What if it is an RA patient recently treated with a tumor necrosis factor alpha inhibitor? They might have a variety of things, one being pneumocystis pneumonia, which we're going to talk about today. What about a recent long flight? Does that change how you work this up? That's what are you thinking about on a flight? PBT, flash, pulmonary input. Lastly, what if they had a recent history of malignancy? This could be like a metastatic manifestation, so. This is why we need to really get a good history. Get a great good history that is gonna be key to working up their infectious diseases. So our treatment considerations, basically, for some of those, they're self-limited, need to be supportive care. Others, antibiotics, antivirals, antifungals, antiparasitics, antitoxins, or incision drainage. And with the antibiotics, I'm not gonna go into depth, but definitely you wanna think about the empiric treatment for that possible, the most likely organism, or whatever you're thinking that it is. Safety profile, allergies, cost, the route, can they swallow pills? Are they gonna throw it up? That kind of thing. So definitely keep all of these things in mind. And then antibiotic stewardship, and I'm not for sure if Dr. Noel talked about this or not, but typically, it's an effort to improve how we use antibiotics. So if you're working in an acute care facility, they usually have like an ID team that's gonna be like a clinical pharmacist and an ID physician or provider that's gonna help with stewardship and making sure we prescribe them when they're truly needed, or if you're needing, issues, you're having issues with trying to treat, you will have a team, but antibiotic stewardship is super important because we want to fight those resistant illnesses. All right, any questions about the workup? No? Let's get to our next presentation. Then we can try to apply some of this. We're gonna talk about narcotic or fungal infections. Watch HBO's The Last of Us. This side of the room is this. All right, so, for those who, are not familiar with it, it's about a fungal pandemic. Which, if I had to choose between viral and fungal, based on the looks of things, I think I would definitely choose viral, but, we're not gonna do any spoiler alerts. If you like zombie apocalypse, then you'll like The Last of Us. I didn't think I would like it, but personally, it's one of my favorites. So, the movie or the series is based on a fungus called cordyceps, and it is actually a real fungus. It's a real fungus called Orpheo cordyceps unilateralis, which is what you see in the middle picture with the ant. It's a zombie ant fungus. So what the researchers think is that this ant is basically like foraging the bottom of the tropical forest, looking for food, and these spores attach to the exoskeleton on the ant and basically take over its brain. So it says you're gonna go here because it's warmer, and fungus, we like the warm temperatures, that kind of thing. And then while it's doing that and it's kind of penetrating that exoskeleton, it is starting to like heat the innards of the ant, and eventually the ant will die and these little spores pop out the top of the head. So with that, then it's available in the air and it's gonna infect the next ant. So fortunately for us, it only affects insects, like ants and spiders, and not humans. But, if you wanna learn about, some interesting possibilities with fungus, that's a little extreme, but it is pretty good, so. It's a theory. So I'm gonna do some spoiler alert for you. You gotta watch this. Okay, so we'll talk about immunity. So unlike bacteria and viruses, which are targeted by antibodies, fungus or fungi have unique cell structures that make them less susceptible to the antibody-mediated mechanisms. When we need to fight fungus or fight a fungal infection, we have to heavily rely on our innate immune system or an innate immune response. So if your immune system is weak, it's gonna be hard to fight, right? Hard to fight fungal infections. And you're gonna be more susceptible to infection. So who is likely to be at risk? Well, this course, a lot of it is surrounded by, is in the context of AIDS patients. Who else would be at risk? Weakened immune system.
Infants.
Hmm.
Infants.
Infants?
Yeah.
Good, yep. Cancer. What treatment do cancer patients need that might make them have a weakened immune system? Chemo, yeah. We have steroids, patients who've had organ transplants or stem cell transplants, patients who've had a lot of antibiotics, their immune system might be somewhat weakened. Outside of a weakened immune system, other patients who might be susceptible to fungal infections are obese patients. Patients who have exposure to prolonged moisture, so think about sweaty feet, sweaty body parts, that type of thing, or poor hygiene. Incidence of nearly all fungal infections has risen substantially compared to years past. They believe this is due to intentional immunosuppression, increased antimicrobial use, and monoclonal antibodies, which we use in cancer, Crohn's, and more recently, COVID. Notably, there is no public health surveillance for fungal infections like candidiasis or, vaginal candidiasis or ringworm. We're gonna talk about terminology real quick, just so you know, when we're talking about different conditions, what is what. So first is yeast. These are rounded solitary cells that are reproduced by budding. That's the top picture. Second picture is a filamentous form, which is a mold. You might hear the word hyphae or hyphae. These are also where your spores are released. There are different variations within yeast and mold. Candida infects tissue, both yeast and filamentous forms may be present. Cryptococcus only exists in yeast form. And then there's the dimorphics, which have the ability to live in both yeast and filamentous form, depending on temperature. And some examples of those are blastocystis, pseudococcidiomycosis, pseudococcidiomycosis, histoplasmosis, sporotrichosis, and Amantia. Amantia is extremely rare in humans. I just put it down there because it's one of the skin manifestation type fungus. that you might see that looks different than your typical ringworm. That one looks pretty yucky. They do see that in South Africa in HIV patients, but again, it's very, very rare. That is not for you to memorize. We're gonna talk about several of those in detail. So, still thinking about terminology, there are endemic mycoses and opportunistic mycoses. Endemic, which would be examples of your coccidioidiomycosis and histoblastosis. These are naturally present in specific regions. And most patients acquire these infections by inhalation of spores in that environment, typically the soil. Opportunistic, which you're gonna hear a lot about in this, because we talk a lot about AIDS, Candida, Aspergillus, and Cryptococcus. These are typically components of our normal flora or our human microbiota. But they're easily acquired by immunocompromised patients. So what was harmless or is harmless to someone that's healthy can be invasive in someone who's not. That makes sense. We also have a couple of different types of fungal infections: superficial, subcutaneous, or deep. The superficial, we think about skin, nails, mucous membranes, so fungus that affect our mouth, throat, or genital areas. Subcutaneous, this might be from a wound or a cut. You scratched your finger with a thorn, and then the fungus is able to enter that way. And then the deep or invasive, which can spread throughout your body, so your lungs, your brain, your heart, and those are the ones that some of those are opportunistic. This is not on your comments for infectious disease. I'm assuming you all got it in derm or some other course, but we're just gonna do like a brief overview. Just because it is part of the fungal infections. So these are your dermatophyte fungal infections. And these are usually human to human contact, but can also be from environmental contacts. Corporate. Does anybody remember how that is spread? Or anything about it?
Wrestling mats.
Wrestling mats, yeah. And the sharing of the fomites could be from mats, bedding, towels, sharing those types of things. You might do that. You all, talked about treatment with Dr. Noel. Does anybody remember what he said this type is treated best with?
Basil.
Or what commonly is treated best with? Hey, somebody said it.
Ketoconazole.
Azoles. And can you take those oral, topical, both? Probably for the most of those. What about contraindications to azole? What's one thing you have to be worried about? Patients taking what types of medications?
Except for CYP 3-4.
Hmm.
So stop.
What'd you say? Statin?
Yeah,
Statin.
like CYP.
Warfarin. Those types of medications. That's just from, that is definitely something you want to be mindful of when prescribing. He also talked about onychomycosis for the toenails, and he said something about treatment when I watched that lecture. Is it the same duration of treatment? Shorter or longer? Longer. Right, very good. It takes a lot to get down there, so you also need to wait on those toenails to grow out, so that's gonna take a while. When you're thinking about your differential and you're looking at all of these, what are some of the things that might come up in your differential?
Dermatitis.
Contact dermatitis, yeah. What else? Eczema. Psoriasis. I put a resource in your notes at the bottom about annular lesions or circular type lesions. that has like a comparison sheet, so you can think about those, when you're looking at trying to build your differential. So you can use that as a resource if it's not to memorize. All right, so our fungal diseases, candidiasis, cryptococcal disease, histoplasmosis, pneumocystis, and aspergillosis. Aspergillosis wasn't on the commons list, but you probably will see it in your pants. Dr. Murphin, I used some of her notes, so likely that was included because you probably will see that on your pants. Of these that we have listed, candidiasis, cryptococcal, and pneumocystis are AIDS-defining illnesses. Does anybody know what that means? We haven't talked about it. We're gonna talk about it Thursday. We'll talk about HIV and AIDS, but an AIDS-defining illness is basically a serious or life-threatening, opportunistic, we said that word earlier, opportunistic, what was normal in the healthy patient is now invasive in the immunocompromised patient that occurs in HIV patients. Have you all talked about AIDS or HIV at all? Much? No. So if the patient has an AIDS defining condition, then they usually, well, we'll talk about it Thursday, but basically there are some things like even if you just present with this illness, it's like HIV or AIDS until proven otherwise. So, we'll talk about that more in detail. Candidiasis. So this one you've seen quite a bit in previous lectures, so we're going to do some review, but we're also going to talk about it in the context of fungal infections and infectious disease. So candidiasis, Candida albicans is part of the normal flora, but it is also an opportunistic pathogen. The infections can range from the thrush, vaginal candidiasis, to systemic diseases. There are also invasive forms that can affect the peritoneum. You can have invasive fungal endocarditis, pericarditis, meningitis. The status of your immune system is the key to how the disease presents. If your immune system is super weakened, then your disease presentation will probably be more severe than someone who is not. If you have a patient that has recurrent oral thrush or recurrent vaginal candidiasis over and over and over again, you keep seeing that same patient. Why do you keep getting thrush? Why do you keep getting yeast infections? You need to think HIV. You need to test them. You need to think HIV. Or diabetes. Diabetes, they also will have these recurrent fungal type of infections. So what are we going to see? This is in general. This is in general for fungal infections for some patients. And this is limited. This is not a full description, but you could have painful or pruritic erythematous rashes, that white curd-like exudate we see. Some patients will complain of burning and itching after sexual intercourse. The exam might show small papules with blotchy erythema or an eroded, dry, or glazed or shiny appearance. Diagnosis for some conditions can be made clinically. Oh, that looks like yeast in your mouth. We're going to treat it as such. Some patients might need a wet prep with potassium hydroxide. Some may need a blood sample or a biopsy. So it just depends. The first one we're going to talk about is oral pharyngeal candidiasis. And I put on here several different pictures of how it might present in the office. We're going to talk about two of these. We're going to talk about them all, but two of these I want you to pay particular attention to, and we'll come back to that. So, thrush. Thrush is a common local infection of the mouth and throat, seen in infants and older adults who wear dentures, individuals who may have poor oral hygiene, diabetes, anemia, patients treated with antibiotics, steroids, including inhaled steroids or chemo. What are the symptoms? They may complain about a fluctuating throat or mouth discomfort, mouth is sore, throat is sore, cottony dry feeling in the mouth, their taste is disturbed, they may have trouble swallowing, They can have painful denture stomatitis, or they may not have any symptoms at all. What are our exam findings? So these patients may have white curd-like patches or plaques that are easily scraped off. Easily scraped off. Easily scraped off. You can scrape them off. You can use a tongue depressor and scrape it off. You don't have to be able to get it all, but if you do see some of it move, you need to think candidiasis versus like a leukoplakia, which is stuck on. When you scrape that off, usually there's a red base. In denture wearers, it might be a painful red palette. So let's go back to that picture. In the top corner. That red erythematous, look on the palette. Now, we can see she doesn't have any teeth, so she likely was a denture wearer or he. If you do not have your patient take out their denture, how will you ever see that? How will you ever see that? Oh, my mouth is sore, I'm having trouble swallowing. I've had patients in ENT. And they'll come to us, well, they said they, they can't figure out what's going on with me. I'm like, have they taken out your teeth? Have they taken out your dentures? Nobody's. No, they never took it out. And a lot of patients will fight you on it. They don't want to take it out because they put all their adhesive in there for it to stick, and they're like, now it's gonna fall out every time I talk. I don't want to take it out, but you're gonna have to be a little bit on the pushy side. I really need to take a look in there. Especially if you're not able to figure out what it is. You need to try to convince them to take it out so you can take a look, because that may be hiding underneath it. And most patients aren't taking a look to see what's going on in the palate, so they don't know. So that's definitely something to keep in mind. Take out those dentures. So exam findings, we talked about, there may also be a manifestation of angular cheilitis, which was on the other picture, which we'll go back to that as well. Because I've had a ton of patients that come in, no white patches in the mouth, no red palate, but they have these in the corners of their lips. That can be a sign of fungus. Sometimes it's bacterial, but it can be a sign of fungus. So these are different things you should be thinking when you're treating patients with particular complaints. If you see that, you want to treat that. Diagnosis, typically made clinically. More than likely, you see it, you're gonna probably think, okay, this looks like thrush, and you will treat it as such. You're not gonna swab every patient that comes in with thrush symptoms. You're not gonna, for the oral pharyngeal type, you're not gonna swab everybody. I will tell you that even in ENT, in swabbing and taking cultures, LabCorp, Quest, they take about 4 to 6 weeks to turn around your fungal samples. So you're gonna make your patient wait 4 to 6 weeks, you're gonna treat it. And if it doesn't respond, then you know, okay, well, at least we have our sample coming back and we might be able to get that. Now, there is a lab called Microgen that does PCR and DNA sequencing tests, which will get your results back in like a week. They're very, very good. They'll give you every virus, bacteria, fungus, and possible treatments, IV, IM, oral. They'll give you everything, but most insurance don't pay for it. And if you have to pay for it out of pocket, it's about $200, and most patients are like, no, I'm paying for that. So we're definitely not gonna swab everybody. If you see something, you want to treat it. If you need to take a swab, then you can, but just keep in mind that that turnaround time can be long. Treatment for oral candidiasis. Does anybody know what we might treat? Fluconazole? Yeah, we're gonna treat it with azole, fluconazole, itraconazole, ketoconazole. There are cetrimazole troches, which I have prescribed quite a bit in my statin switch and swallows, which we prescribe quite a bit in DNT. And you want to treat the denture. You cannot just treat their mouth. They need to treat their denture too, especially if they have that type that we looked at on the picture. You want to treat the denture. All right, differential diagnosis. These you do not have to memorize. This is to help you think clinically. Okay, but some of the things we talked about with leukoplakia, like I said, if it does not scrape off, you need to be thinking of other things. Lichen planus will not scrape off. Cancer, more than likely, will not scrape off. The ones with the asterisks are the ones for more erythematous type candidiasis. So you can have an erythroplakia. You can have a thermal burn. Your pizza was too hot. You ate it. You sipped your coffee. It was too hot, and it left a red mark in there. So there are things that look very similar. Erythema migraine, and anemia. These are all part of your differential when you're trying to work up these patients. If you treated a patient with the angular cheilitis and they didn't respond to your azole or your topical treatment, you might want to think bacteria. So these are just helping you to kind of think through your workup, think through your treatment, think through your diagnosis. Next, we're going to talk about esophageal candidiasis, which may present with symptoms of substernal odynophagia or painful swallowing, dysphagia, trouble swallowing, GERD-like symptoms, gastroesophageal reflux, nausea without substernal pain. And for this one, it is not always thrush present. You may not see thrush in the mouth. This is an AIDS-defining illness. If a patient has esophageal candidiasis, it is an AIDS-defining illness. It is HIV or AIDS until proven otherwise. You could also have a hematologic malignancy like leukemia or lymphoma. If you see this, most of the time, you're not gonna see this in your office. These patients are complaining of these symptoms. You're treating them like it's GERD, or you're treating them, as something, but you're probably not gonna be able to make that diagnosis. These patients are gonna have to be referred, because diagnosis is confirmed by endoscopy with biopsy and culture. So you may see them with some of these symptoms, and you've tried to treat. You're ruling out all these things and nothing's coming back, then you might think in your mind, okay, maybe it's candidiasis in the esophagus, I'm not for sure. Then you need to see a general surgeon, GI or ENT, somebody who can do an endoscopy, take a biopsy and culture it. Typically, it's gonna look like that, white plaque-like lesions in the esophagus. The treatment, depending on the severity, more than likely will be fluconazole. Questions? So this is more of a review because I know you've already done some vulvovaginitis candidiasis. But this is the most common form of mucosal candidiasis. Risk factors include increased estrogen levels, so patients on birth control or those that are pregnant, uncontrolled diabetes, patients on broad spectrum antimicrobial treatment, patients using steroids, HIV. And what are their symptoms going to be? Itching, like cheese-like discharge, dysuria, burning, irritation. Dyspareunia, I'm gonna say that word, dyspareunia, painful intercourse. What do we see on that exam? The same thing you're looking at all these pictures, white plaques on the vaginal wall, curd-like discharge, vulvar edema, excoriations where they've been scratching. And how do we treat it? How do we treat candidiasis, vulvovaginitis? azoles. And are those only oral? No, topical or oral. Candida balanitis. This is white patches on the gland penis or the female shaft, often under the foreskin in uncircumcised male. It might involve the thighs, the gluteal folds, the buttocks, and the scrotum. Typically in uncircumcised individuals, diabetics, or if their partner has recurrent vaginal candidiasis. It can lead to phimosis. Who remembers what phimosis is? You can't pull the foreskin back. You can't be retracted. Do we need to treat the partners? Yes. Sexual partners of men with balanitis should be offered testing to reduce the likelihood of reinfection. And we're gonna treat them with omeprazole or nystatin. Candida mastitis. Did Professor G talk about this in her guide? Topic. This is a painful breast tissue infection, usually in pregnant or breastfeeding women. Symptoms might be breast pain, pain out of proportion to the exam, deep, sharp shooting pains in the breast. Treatment is typically with nystatin or clotrimazole cream. The first picture, you see that red surrounding color to the breast. The second picture is more of a hyperkeratosis of the areola and the nipples, which looks a little bit different. So those are two different variations of how that might present. Can anybody tell me what you would want to be concerned about with that top picture? That looks like something else to me. Could be cellulitis. What's a cancer? Breast cancer. There's an inflammatory breast cancer that looks like that too. Has a classic orange peel. We call it QV orange. I don't know if y'all talked about that yet, but if you see that in a patient, you should definitely have that in your differential. Inflammatory breast cancer has a very similar appearance. I left you two resources about breast manifestations, and there's an article about mastitis for you to look at your leisure if you're interested. Other parts of your differential for mastitis would be breast abscess, especially in a patient with persistent fever, clogged milk duct, and then inflammatory gut. Yes.
So on the PowerPoint we have, a lot of these are blank.
I'll put mine up.
Okay.
Yeah. No, I'll upload the workup and the fungal to your report after class. So our next topic, and then we'll take a break, is invasive candidiasis. This is usually due to candidemia, which is a blood infection, a fungal blood infection in an immunocompromised host. This is a nosocomial infection, a healthcare associated infection, typically seen in ICU patients. This is one of the most common causes of bloodstream infections in hospitalized patients, often resulting in long stays and possibly death. So if your patient has been in the ICU for a long time, this is something to be concerned about. The presentation can vary from fever, mild fever, to septic shock that is similar to a severe bacterial infection. Invasive candidiasis is defined by hematogenous spread to multiple viscera. So it can affect the eyes, the kidney, heart valves, the brain. And who is at risk? Our same patients we talked about, those immunocompromised patients, that's what we're thinking about for most of these fungal infections. So if you got leukemia or lymphoma, you've had an organ transplant, stem cell transplant, you're on chemo, you've had a prolonged, low white blood cell count, neutropenia, recent abdominal surgery or multiple abdominal surgery. If you've had a lot of antibiotics in the hospital, if you're receiving parenteral nutrition, if you've had kidney failure or hemodialysis, these are the patients we are worried about invasive candidiasis. The standard in diagnosis is a blood culture, but the diagnosis is challenging because the blood culture is only positive in 50% of patients. So some of those deep-seated infections are gonna be missed. It's not an easy thing to diagnose. There is a specialized test called a beta-D-glucan, and if that is positive consecutively, you can start to treat patients empirically for invasive candidiasis, even without a positive blood culture. And the first line of treatment is IV echinocandin. And I believe he talked about those last week as well. How do we prevent? Prophylaxis with antifungal agents has been shown to prevent invasive fungal infections in high-risk patients undergoing chemo, bone marrow transplant, or liver transplantation. So prophylaxis with antifungals is the way to prevent that. And then we'll stop here. This is a photo of my patient who came in with trouble swallowing and dysphagia. He is an HIV positive patient. And you can see that exam revealed cottage cheese-like lesion. I could use that tongue depressor and scrape that away. So it's less likely leukoplakia and more likely fungus, especially in an HIV patient. I did complete laryngoscopy, which is what we do in ENT to check his larynx and see if there was any migration into that area, but there was not. So we went ahead and treated him. Fluconazole, treatment with fluconazole over, forget, 7 to 14 days. And then he came back and that's what we saw. So he responded extremely well to the treatment and was feeling a lot better. I did refer him back to his HIV doctor or his IM doctor, whoever manages it, because they need to be aware of his recurrent infections. If he had more, if this is a pattern, I just saw him for the first time coming in with that trouble swallowing. So if there's a pattern or if the CD4 counts need to be checked, that would be up to them. But for me, because we use EMR and I see 30 patients a day, I'm not gonna be able to remember what he looked like when I saw him 2 weeks ago. So a lot of times I'll ask patients for permission. Do you mind if I take a picture? I won't leave your face in it, but I just want to take a picture so that I can have something to compare it to. Of course, I put it in my notes, like cottage cheese, like curd, like or whatever. Findings consistent with oral pharyngeal candidiasis, but I like to be able to look at it and see how much, because it may not have improved much. It might have just improved a little bit, but that helps me to be able to see significant improvement, mild improvement, no improvement. So you may want to, if your patients will allow you to take pictures so that you can use it for comparison's sake when they follow up. So we'll take a 10-minute break. We'll come back at 9:07 and we'll start with the cryptococcal disease transmission. The other cause of cryptococcosis is Cryptococcus gotti, which in contrast usually affects healthy patients. So Cryptococcus neoformans, immunocompromised, and Cryptococcus gotti, immunocompetent. And they present a little bit different. So the transmission is the same for both, through the air. A major cause of cryptococcus, not a major cause, but cryptococcus gatti, they have found in like Northern California. Weird geographic, it's weird one there, but, the Pacific Northwestern region. And it can be more severe than actual cryptococcus neoformans, so that's something just to keep in mind. For test-related questions, PANS-related questions, more than likely you're gonna see the neoformans, more common. And this is the most common cause of fungal meningitis. It can present with lung infection. Those lung infections may remain localized, they may heal, or they may disseminate. Progressive disease is typically in those immunodeficient patients or patients with Hodgkin's, steroid treatment, organ transplant, TNF alpha inhibitors. This is the third most common invasive fungal infection in organ transplant, in organ recipients. The third most common invasive fungal infection in patients who have received an organ. Following behind aspergillosis, which we're gonna talk about, and candidiasis. So the three invasive, most common invasive, cryptococcus, aspergillosis, candidiasis. So we're all gonna talk about candidiasis, and we're gonna talk about aspergillosis. Cryptococcal signs, yes. Yes, the three most common invasive forms of fungal infection are from cryptococcal, candidiasis, or aspergillosis. In organ transplant recipients. Signs and symptoms. If a patient has pulmonary disease, which is less common than the fungals, they may have simple nose, or they can have widespread infiltrates. The lung disease can lead to respiratory failure. The disseminated form of this disease can involve any organ, but the central nervous system predominates. Again, it's the most common cause of fungal meningitis. I'm gonna say it 7 times, so I'm gonna got it. These patients are gonna present with headache, nausea, vomiting, confusion, mental status changes, possibly cranial nerve or visual abnormalities. They may also present with nuchal rigidity or meningeal signs. Does everybody know what nuchal rigidity is? You say yes or no? Yes. 50% of patients with cryptococcus will have this, but it is not something we see typically in our AIDS patients due to CNS. Their response is not the same. We'll talk about that. So there are some specialized tests that we can do for patients with meningeal signs. Does anybody remember what those are from their neurology?
Kearney's and Brudinski's.
What are they?
Kearney's and Brudinski's.
Yes, very good. And we will look at those on the next slide. The first time I saw a patient with nuchal rigidity was in an elective clerkship I did in Swaziland, Africa. And they thought that the patient had malaria. I'm not sure if he was HIV positive. A majority of the adults living in Swaziland have HIV, I think 26–30%. It's a huge population of HIV patients, but that was the first time I ever saw that. And I was a student, so. There are some international opportunities that will be available for you guys, hopefully, when you start your electives. Let's see. So cryptococcus gatti, these patients usually have respiratory symptoms and they may have neurological signs. Cryptococcus neoformans may also present in the skin. So outside of a fungal meningitis, they may also have something that mimics a bacterial cellulitis. So we'll look at a picture of that in a second. Typically, this is seen in patients receiving some type of immunosuppressive therapy or corticosteroids, but again, could be in any immunocompromised patient. And these are your reminders on how to do a Kernig and a Brzezinski sign when you're testing patients. Again, uncommon in AIDS patients. And then it says, in your current book, that communicating hydrocephalus may complicate the course. So that is when your CSF is not, it's produced, but it's not circulating like it should. So you have an excess of fluid. I can think that won't be right. Diagnosis. Diagnosis and treatment. In pulmonary disease, the diagnosis is made by a culture of the respiratory secretions or the pleural fluid. In meningeal, a lumbar puncture is preferred. And on that lumbar puncture, it's going to show a budding encapsulated fungal cell. Those are going to be key words when you're reading your stems. Lumbar CSF revealed a budding encapsulated fungal cell. Or could say India ink. Now, India ink was not in your current, but India ink used to be on the pans over it. It was a common question. That is a type of stain they use for the CSF. It's an India ink technique. So if you see India ink, I want you to think Cryptococcus. Not sure if it's gonna be on there, but I do want you to know that. It's a budding encapsulated cell so with the India ink, it basically creates like a halo around the cells that differentiate it from everything. Demonstration of a capsular polysaccharide antigen in the CSF and a positive culture is diagnostic in over 90% of cases. MRI is going to be better than a CT scan for patients with meningeal forms of the disease. And anybody recall the treatment from last week for severe progressive systemic fungal infection? Starts with the A. Amphotericin B. So these patients are going to be treated. Sorry. Going to be treated with amphotericin B followed by fluconazole and possibly the addition of cytosine. That's been shown in HIV patients to improve their survival, but toxicity is common. And in HIV patients, they need prophylaxis. They need fluconazole therapy long-term for maintenance. I believe it's like 6 to 12 months for maintenance in an HIV patient. You will continue the treatment for Cryptococcus until your CSF is clear. They're gonna, until the culture is clear, you're gonna continue to treat that.
Professor White,
Yes,
so is the prophylaxis fluconazole, that's like, you said that's just 8 to 12, how long did you say it was?
it's about 6 to 12 months.
Okay, and that's prophylaxis, but it's after diagnosis. But
After diagnosis and treatment, then they're gonna get this maintenance therapy with the fluconazole for about 6 months or more, depending on the patient. So it's a long treatment. You can see 14 days with the amphotericin B, then 8 weeks of fluconazole. And then after that, once the CSF is completely cleared, if it's an HIV patient, they're gonna get on that maintenance therapy. This is more so a resource. I'm not for sure what I was talking about in your neurology, but you'll remember those opening pressures, their proteins, they're decreasing the glucose. These are not anything that we need you to know for this test, but when you are trying to differentiate between a bacterial, a viral, or a fungal meningitis, then these are the things that you should be looking for in fungus, an increased opening pressure, increased protein, possibly decreased glucose. So cryptococcal pneumonia, again, it is the most common cause of what?
Fungal meningitis.
Fungal meningitis, but it can occur, you can have pulmonary disease. It is not easy to diagnose because it can have a variety of presentations. These are all the possible presentations. So not very easy, to diagnose because of that varied presentation. I think I left a resource at the bottom for the Great Mimicker, which talks about the different presentations of cryptococcosis that you can look at in your leisure if you have time or if you're interested. But again, this is where your history comes into play, your medical history. What is your medical history? Tell me about this, tell me about that, because it could look like a pneumonia. It could look like so many different things. So you want to really do a good job as a clinician and try to get as much detail as you can. This is also more so a reference, just so you can see the skin variety of the Cryptococcus neoformans. And we said on that, when it does affect the skin, it can mimic bacterial cellulitis, which is what the B picture looks like. So you can see how similar those presentations might be. Again, while you're thinking of multiple things when you're seeing patients. Like so important to try and build a differential diagnosis. That looks like bacterial cellulitis. Really, it's for this. So other parts of your differential, again, this is not anything you have to memorize. This is to help you kind of sort through basal cell carcinoma, histoplasmosis, which we're going to talk about, lipomas, pneumocystis, which we're going to talk about, toxoplasmosis, TB. Various things can look like cryptococcosis. But what do I want you to remember? It is the most common cause of what? Where is it found? Soil and pigeon dung. That is a STEM question. Soil, pigeon dung, fungal meningitis. If you have a patient with fungal meningitis and HIV, it's thinking cryptococcosis. Okay. How do we test it? CSF. And what does it show? An encapsulated budding yeast. Encapsulated budding yeast on CSF. It might be done with the India ink technique. So these are things you're gonna see on your test. Possible. And we treat it with, we treat for those severe invasive infections. Starts with an A. Followed by maintenance for HIV patients. These are things you should be thinking about. Who does it affect? How do I diagnose? How do I treat? How do I confirm? Those are the things I want you to think about with these. And this is what your differential is. I will say that the fungal infections are very similar, so not in all ways, but you'll see them on the differentials usually contain, they are on each other's differential for most of these. All right, let's talk about histoplasmosis. Histoplasmosis is caused by Histoplasma capsulatum, which is the most prevalent endemic mycosis in the US. What do we say about endemic versus opportunistic? Endemic is in a certain geographic region, right? So this is the most prevalent endemic mycosis in the US. This can be, this is a dimorphic fungus. So dimorphic meaning it can live in two life cycles. It can be a yeast and a mold. It is found in soil contaminated with bird droppings or bat guano. Bird droppings can include chickens. Bird droppings can include chickens, and we see it in these areas of the United States, central and eastern United States, eastern Canada, Central and South America, Mexico, Africa, and Southeast Asia. They believe 60 to 90% of people living in areas around the Ohio and Mississippi River Valley, as well as Missouri River Valley, I didn't add that one in there, have been exposed to the fungus at some point during their lifetime. So I grew up in Kentucky, born and raised, went to school there, and grew up in the Ohio River Valley. So I may have been exposed to the platinum capsulatum at some point in my life. But most of these patients, or most people that live in those areas have been exposed to something. Worldwide, it's common among HIV patients or those with an weak immune system. So if you look at where we find it, we said it's in the soil that's been contaminated with bird droppings or bat guano. What occupations do you think are at risk? Or what activities might someone do that may put them at risk? Farming. What do you say?
Wander in a cave.
Cave, yes. If your stem says 26-year-old cave explorer comes in with da 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 da, I want you to be thinking about histoplasmosis. Cave explorers, farmers, gonna be big ones. All right. Patients with HIV tend to have a poor prognosis when it's contaminated. So this is your biology, like kind of how it passes through in those areas, those endemic areas that are affected. Like the Maryland, that picture. The mode of transmission, infection presumably takes place through spore inhalation. So the spores are converted into small budding cells that are engulfed by the phagocytes in our lungs. The organism then multiplies and goes and undergoes this lymphohematogenous spread to other organs. So spore inhalation, soil contaminated with bird droppings or bat guano, Ohio River Valley, Mississippi River Valley, Missouri River Valley, cave explorers, farmers, patient who has a chicken farm, who raises chickens, but if you see any of that, I want you to think histoplasmosis. Who is at risk? Patients with impaired cell-mediated immunity. So this is our immunocompromised group again. And like I said, just be familiar with who will be immunocompromised throughout the lecture. And you'll see it next week, or Thursday. Patients with AIDS, other immunosuppressive disorders. Do you have a question, sure?
Yeah, I'm just wondering why this word more likely.
It's something in the environment, in that particular like climate of the environment. It's something with the Ohio River Valley, so Mississippi and Missouri River Valley, that river area. The soil and the climate in that area associated with those rivers. Yeah. So yeah, it's just endemic to those areas, that's what they say. Endemic usually is something with that region, something specific about that geographic region, something specific about that climate, something specific about the environment that is making that more likely. Infants and older adults are at risk. Organ transplant patients are at risk. And patients with COPD. Now, histoplasmosis it's usually not a cause of COPD, but it can contribute to lung damage and fibrosis, which can make your patient with COPD have worsening symptoms. Or put them at risk for developing COPD, but it typically is not a direct cause of the condition. For most patients, histoplasmosis is asymptomatic, self-limited, mild, never even know about it. If they do have symptoms, sometimes they'll come in with a respiratory illness or flu-like symptoms. And those only last a couple of days, 1 to 4 days. Patients with moderately severe infections are frequently diagnosed with an atypical pneumonia. They're not diagnosed with histoplasmosis off the top. They're saying, oh, this is just an atypical pneumonia. Those patients have fever, cough, mild central chest pain that lasts 5 to 15 days. And what did we say one atypical pneumonia is? We just talked about earlier. Chlamydia pneumonia. And that is often seen in school age and young children. And most of them can recover without treatment, but that's what it is often diagnosed as. In an immunocompromised patient, they may have long-term lung disease. Again, they may have a poor prognosis. On chest X-ray, you might incidentally find pulmonary or splenic calcifications. That may be evidence of a past infection. So histoplasmosis is clinically evident in several forms. The first being acute pulmonary histoplasmosis. This occurs in epidemics when the soil containing infected bird or bat excrement is disturbed. So this is going to be affecting several people at one time. These symptoms usually can last 1 to 6 months. They may have, again, those mild flu-like symptoms, but they could have pneumonia as well, but usually this is not fatal. The next form is progressive disseminated histoplasmosis. This is most common in patients with underlying HIV. And what you're going to learn on Thursday is patients with HIV, once their CD4 count drops below 200, they're considered to clinically have AIDS. So this is in HIV patients, AIDS patients with a CD4 count less than 100. There are different levels to that CD4 count. Patients with a 200 to 300 to 500 CD4 count, patients with a 200 CD4 count, patients with less than 100, patients with less than 50. And their disease severity gets worse as those numbers continue to fall. We'll talk about that. Also, patients with tumor necrosis factor alpha inhibitors from those same endemic areas where those bird and bat droppings are contaminating the soil. Those patients tend to be at higher risk. Patients with progressive disseminated histoplasmosis may present similar to septic shock. Typically, they have rapid death without treatment. There may be a miliary pattern on the chest X-ray, and there might be liver and spleen enlargement noted. These patients might present with fever, trouble breathing, cough, weight loss, exhaustion. They could also have ulcers in their mouth. And this chest X-ray appearance can look very similar to sarcoidosis, miliary TB, metastases. Our first one we talked about, cryptococcosis. The cryptococcus can look similar to that as well. The third form is chronic pulmonary histoplasmosis, which is usually seen in older patients with chronic lung disease, like COPD. These patients present with chronic pulmonary changes, progressive pulmonary changes. Something's going on, COPD is not getting better. Of course, this is where your workup comes in. If you're going to do some updated imaging, more than likely, run some tests or things like that. And lastly, complications. The last form is complications of pulmonary histoplasmosis. These patients have persistently enlarged mediastinal lymph nodes and fibrosing mediastinitis. Mediastinitis occurs due to excessive fibrotic response to the infection, and it can change your vascular structure. This is rare, 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 rare. So when we think about it, it's more likely going to be that it's pulmonary hyperosmosis. Your cadence working in with mouth like symptoms, blah, blah, blah. Chicken farmer came in with cough, shortness of breath, or something like that. So that's what we're looking at with that. The diagnosis and treatment. Histoplasma has an affinity for the reticuloendothelial system. So it typically can involve the liver, spleen, your bone marrow. When you think about that, think about ways you're diagnosing, different ways to look at how you're diagnosing. So your pulmonary patients with a pulmonary pulmonary disease, their labs may show anemia of chronic disease, which I know Professor Newman talked about in her ticks types of anemia. So they may have signs of anemia of chronic disease. Their bone marrow may show pancytopenia in disseminated forms. Commonly, they may have an elevated AST, alkaline phosphatase and ferritin, and a marked lactate dehydrogenase elevations. Urine antigen assay and blood and bone marrow cultures can be useful in diagnosing the disseminating form. There is also antigen testing for bronchoalveolar lavage fluid, which can be helpful in the acute form of the disease. Treatment. Well, if it's asymptomatic and you don't have any symptoms, you don't need to do anything. But if you have mild or moderate infection, fluconazole, itraconazole is preferred over fluconazole. In studies, fluconazole showed less favorable outcomes. So you would start with itraconazole if possible. Severe would be amphotericin B. Remember, Dr. Noel, severe invasive amphotericin. So we're gonna start with itraconazole, first line. If the patient has severe symptoms, we're gonna do IV amphotericin B. AIDS patients require lifelong suppression therapy with itraconazole. So see the pattern. For the doctors, they need maintenance therapy. Histoplasmosis, they need maintenance therapy. For patients that are not HIV positive, you can stop the antifungals once your chest X-ray is clear. The differential is green. It is a lot on here. You don't memorize all of these. I bolded those most common ones. Aspergillosis, which we're gonna talk about last. Chlamydia, idiomycosis, mycoplasma, sarcoidosis, TB. It could also be a viral or fungal pneumonia. It could be a small cell carcinoma, small cell lung cancer. It can be several different things. I should have bolded pneumocystis jirovecii, but I did not. That's down above sarcoidosis. We'll go ahead and start with that one. Pneumocystis pneumonia. Pneumocystis pneumonia or pneumocystis jirovecii pneumonia is a potentially life-threatening infection in the lungs. When I was in school, we called it pneumocystis cardiac pneumonia, or PCP. They still call it PCP, even though that's not what the abbreviation is for Jarlbecki anymore. But you will still see PCP being used. So pneumocystis Jarlbecki pneumonia or PCP. Some people do PJP, but PCP is still more likely used. Initially, it was classified as a protozoa, but it was reclassified as a fungus. The life cycle for a protozoa and fungus for this particular infection is very similar. So initially they thought it was a protozoa, but they have now determined it to be a fungus. It is a major cause of pneumonia in immunocompromised patients. It occurs in up to 80% of patients with AIDS who are not receiving prophylaxis. It is probably the most opportunistic pathogen in the HIV community. Pneumocystis, Infectious, most common cause of pneumonia in immunocompromised patients, and the most opportunistic pathogen in the HIV community. Patients with autoimmune or rheumatoid disease are also at risk for pneumocystis pneumonia. Studies suggest that it is airborne, but they don't know where it comes from to get into our lungs. So they suspect it's some type of airborne transmission, but they don't know the source. Just like we said, the source for Histoplasmosis was the soil that's been contaminated with the bird and bat guano and the cryptococcus. You know those sources where it came from. But for this one, they don't know where it comes from to get into the lungs. Evidence of infection can be found in almost all people from a young age. Most individuals' immune systems have fought it off by the time they're 3 or 4 years old. And most people within a weakened immune system, they can be very, very sick with this. Studies show that 20% of adults might carry this fungus at any given time, but our immune system removes it after several months. So this is our opportunistic type of infection. Opportunistic. Give me an opportunity to wreak havoc on your immune system. Your immune system is weak, and I can attack. Your immune system is strong, then I can't do anything, right? So our signs and symptoms, this is typically an overt subacute interstitial pneumonia. These patients are going to present with fever. They're having shortness of breath on exertion. They have a non-productive cough. They might have bivascular crackles. Not everybody has, some auscultations are normal, but for some patients, they may have crackles. The exam findings are disproportionate to imaging results and the degree of illness. 5 to 10% of patients have a normal chest X-ray. Less commonly, some might present with spontaneous pneumothorax. So, for this pneumonia, patient presents with fever, abrupt onset of fever, shortness of breath with exertion, non-productive cough. Need to be thinking fever, abrupt, and especially an HIV patient. Patient has been tested for HIV in the past and found to be positive, presents with fever, dyspnea on exertion, non-productive cough, PCP. Diagnosis, the chest X-ray is going to show diffuse interstitial infiltrates that could be heterogeneous, miliary, or patchy in early infections. Could be normal. Non-specific, remember 5 to 10% of patients have a normal chest X-ray. There may be diffuse or focal consolidation, nodules, cystic changes or cavitation within the nodules. So a variety of presentations there. A dominant finding is the ground glass appearance. You see ground glass appearance that should be in your differential. PCP. There are several things that may present with a ground glass opacity. Pneumocystis should be in your differential. CT scans are more sensitive than chest x-rays. Arterial blood gases might show hypoxemia with hypopnea, or it could be normal. If you do a PCR of the bronchoalveolar lavage fluid, and it's negative, that rules out PCD. A negative PCR of the bronchoalveolar lavage fluid rules out PCD. That beta D glucan we talked about earlier in invasive candidiasis can use that and have sensitivity, but it lacks specificity. This organism cannot be cultured. Here are two various presentations of PCP on a chest X-ray. You can look at them, see what looks unusual, and just look and see how different they are. So we want to treat and prevent. So how do we do that? We're gonna start empiric therapy for pneumocystis jirovecii pneumonia. If the disease is suspected clinically, you are not going to wait. Do not wait for confirmation. Do not wait for confirmation. These patients will die. High mortality if untreated. So we're gonna start it. Your HIV patient came in with abrupt onset of fever. They have a shortness of breath. They have a non-productive cough. Treat them. And the preferred treatment is trimethoprim, sulfamethoxazole, or Bactrim. Well, that's an antibiotic, right? This is a fungus. So this does not respond well to antifungals. This does not respond well to antifungals. It has been shown to be responsive to Bactrim. PCP is not responsive to antifungals. You will treat this with Bactrim. There are some alternatives to replicating not tolerate Bactrim. HIV and AIDS patients have a lot of hypersensitivity reactions to Bactrim, including fever, rashes, malaise, neutropenia, hepatitis, hyperkalemia, hyperbilirubinemia. You have to be careful with those. That occurs in about 50% of AIDS patients. Alternatives, the second line would be Primaquine. And I believe Dr. Noel talked to you about this. Do you remember who you cannot use Primaquine in? The type of deficiency.
Oh, G6P.
Yes. G6PD because it causes hemolytic anemia. So same for these patients you want to avoid. And alternatives. We have several alternatives there. Dapsone is one you all talked about last week. Does anybody remember talking about Dapsone? It is expensive, but it is an alternative. It is also contraindicated in patients with a 6PD deficiency. Additionally, prednisone. So studies have shown that adjunctive corticosteroids in 72 hours from diagnosis is preferred in patients with HIV and AIDS. additionally prednisone, especially if you have moderate to severe pneumonia. They suggest that it reduces the mortality and morbidity of the disease. Prophylaxis, again, we're treating prophylactically in HIV patients, especially if your CD4 count is less than 200. Prognosis, fatal if it's left untreated. Fatal. Have to treat this. Early treatment is better. It reduces the mortality in 10 to 20% of our HIV patients. And other immunodeficient patients, their mortality rate still is about 30 to 50%. Probably because of delayed diagnosis and not being for sure exactly what's causing their symptoms. There are recurrences, with no prophylaxis. So again, treat prophylactically those patients, especially with immunocompromised, statuses. Yeah.
So when you say treat prophylactically, you're treating it because their risk of reinfection is high?
Yeah, because their immune system is weak and they can be reinfected or get any infection. So once they've been treated for histoplasmosis or PCP or cryptococcus, they need to be on some type of prophylaxis, some type of maintenance therapy to prevent these fungal infections from recurring.
Okay.
Because their immune system just is susceptible to infection. So they should be on some type of prophylaxis. Differential is grand. Acute respiratory distress, cytomegalovirus, mycoplasma, pulmonary embolism. I believe these are click and control, so if you want to click on them and then read about those particular ones, I try to find a site that would allow you to do that. I added at the bottom, sarcoidosis, adenocarcinoma, aspergillosis, and cryptococcus, sorry. Yes.
What kind of prophylaxis should they do?
So I don't have that specifically, but it's gonna be some type of, antifungal, even though PCP does not respond to that, it responds to the Bactrim, they still need to be on some type of antifungal prophylaxis, because that's what we just talked about with that recurrence. All right, let's take another 10, and then we'll talk about aspergillosis. And Aspergillus flavus. Most of us breathe in aspergillus spores every day and do not get sick. They are filamentous fungi. Filamentous meaning hyphae versus the rounded cell. They're filamentous and they're multicellular, so they create this dynamic network of hyphae when they're produced. It's a common indoor and outdoor mold. You can find it in plants, soil, rotting vegetable matter. It can be found on dust, in ground spices, and also in building materials. It is the most common cause of non-candidal invasive fungal infections in transplant recipients. We talked about 3 that can cause fungal infections in organ transplants. And this is the most common non-candidal form. It is also not uncommon to see in patients with lymphoma or leukemia. And it largely involves the lungs, the sinuses, and the brain, causing allergic reactions and lung infection. There are several types of aspergillosis. The first we're going to talk about is allergic bronchopulmonary aspergillosis. These patients usually have some type of pre-existing asthma, maybe even cystic fibrosis. This is a lung inflammation with allergy symptoms. Patients have coughing, wheezing, worsening bronchospasm. Allergic bronchopulmonary aspergillosis. Then there's allergic aspergillosis sinusitis. These patients usually have some underlying allergies, They'll present like a typical sinus infection would. Drainage, stuffiness, congestion, headache. I have seen aspergillosis in the sinuses before. Typically, I found it in younger patients, but it can occur at any age. These patients typically do have underlying allergies and have to have some type of therapy for their allergies to control the fungus in the sinuses. The end-all treatment for that is surgery, but we'll talk about that in a few slides. The third form, for the sinus patients, those patients, you'll also find polyps in their nose. They usually have a more polyp than a patient with polyp. Chronic pulmonary aspergillosis is the next type. Aspergillomas may also present in the lungs, which we're going to show in the next slide. It's like a fungal ball. These patients usually have pre-existing lung damage. Their symptoms can be long-term, lasting 3 or more months. It can cause a chronic fibrosing disease. It can present with cough, shortness of breath, weight loss, and malaise. Invasive aspergillosis is the most severe. Of all the types, the invasive aspergillosis is the most severe. Because it's a serious infection. Profoundly seen in immunodeficient or immunocompromised patients. Two of the most commonly reported fungal infections in patients with severe COVID-19 is invasive aspergillosis and invasive candidiasis. That's why COVID-19 is there. So you will see this in those patients as well. Most commonly, it affects the lungs, which can lead to severe necrotizing pneumonia, but it can spread to the CNS, skin, and other organs. There's also a skin form, cutaneous form of aspergillosis. We said that the disseminated disease can affect the skin, but you can also get cutaneous skin aspergillosis through a break in the skin. Usually after surgery, or if a patient has burns, you're treating wounds from burns, you might see this type of fungal infection of the skin. And then there are azole-resistant Aspergillus fumigatus. So the patients that are not responding to azoles. So this is the picture of the aspergilloma, which is a ball of aspergillus that grows in the lungs or the sinuses. On the sinus picture, and I'm not sure how much prepping we did if you would stand, but that you can see here, this would be typically your normal black air in that left sinus. Over here, you can see it's completely filled. You've lost the septum. The wall of the septum is gone, so it's completely like eating away through that bone. And it's getting pretty close to that eye here in the ethmoids. So you can see that that's completely still in that space. That's why I said that this has to be surgically removed. Have to remove that in the sinus patient. And down here, you'll see that fungal ball on CT scan. So these round balls of fungus that are growing, and usually do not spread to other parts of the body. They're pretty isolated. Signs and symptoms, well, that depends on what type of infection. We just talked about 5 different types of aspergillosis, so it's really going to depend on the type of infection that you are looking at or thinking about. You could do some imaging, possibly plain films, CT, MRI. Procedures would include bronchoscopy, possible nasal endoscopy, if it's sinus, biopsy, if it's cutaneous, and other areas that you're concerned about, CBC and blood cultures. Some labs offer PCR testing, so you could possibly do that. This is important. On microscopy, septate hyphae with an acute angle branching. If you see that in a scan, it shows septated hyphae with acute angle branching under microscopy, you should be thinking about aspergillosis. Definitive identification is difficult to make alone, because it's insensitive, but when positive, you might find filamentous fungi on the testing, so. Here are some examples. So you'll see that big aspergilloma in that upper lobe of that lung, and on autopsy, what that aspergilloma looks like. That is in a patient with sarcoidosis. Treatment for our allergic form, we're going to treat with itraconazole plus or minus corticosteroids. There are a variety of treatments for the invasive and chronic, and it's all going to be dependent on what you're treating, the severity, and a bunch of different things you should be considering. For the invasive and chronic, voriconazole or isavuconazole, amphotericin B, or the echinocandins, that capsopungin. The echinocandins are recommended for the azole resistant type as well. The echinocandins are for the azole resistant type of aspergillosis. Again, surgical intervention for sinusitis, surgery is the answer. And then they probably will need some type of allergy treatment, underlying allergy treatment to control that. Systemic antifungals for fungal sinusitis is very controversial, so we're not going to talk about that, but just no surgery. Sinus aspergillosis, fungal ball in the sinuses, treat with surgery. If you have local pulmonary lesions that are causing like hemoptysis or some type of severe issue, they may need some type of surgery as well. That aspergilloma in the lung might have to be removed, or if patients aren't responding to therapy, there may need to be surgical intervention for that as well. This is treatment just in chart form for patients who are all like charts. So you'll see that allergic, itraconazole, possibly corticosteroids, the invasive, the voriconazole, the amphotericin, with the echinocandins, and then aspergillosis, possibly surgery or antifungal medication. Treatment for invasive and cutaneous, when possible, immunosuppressive medications should be discontinued or decreased to try to help build up their immune systems a bit. But again, people with severe cases may need surgery. This differential is very overwhelming. We don't expect you to remember all of these, but keep in mind that aspergillosis presents in 5 different types of forms. So there may be some that are more related to allergy, there may be some more related to sinuses, there may be some more related to the lungs, but this is what Medscape has down for the differential. So you can take a look at those and just kind of get in your mind some different things that you may be thinking about. Any questions about aspergillosis? Yeah. All right, so what do we remember? So let's think about all the fungus that we talked about today. Your hand only have a few of these on here. Your comments only has the top four. So there's something unique about each of them. So we talked about the diarrheas last week, and we talked about a lot of things that were very similar. Diarrhea, nausea, vomiting, or abdominal pain, or this or that, fever, blah, blah, blah. There are hallmarks for these. So what can you tell me, about the microscopy on the aspergillosis? We just talked about it. What type of hyphae is it? Septated with acute branching. Pneumocystis pneumonia. What is different about that? What's the hallmark of that one? Who is it affecting most?
It's
HIV patient. And how are they gonna present?
Dyspnea, not productive.
Fever, rough fever, dyspnea on exertion, non-productive cough, dry cough. What about histoplasmosis? Where is it found? Soil contaminated with what? Fat, guano, and does that include chickens? Yes. So who are our occupations we're worried about? Farmers, who else?
Cave dwellers.
Cave dwellers, exactly, good.
How many of those you gonna encounter?
For,
No, I'm sure it would be. honestly.
cryptococcus. What do we remember about that one?
Pigeon.
Pigeon, yep, pigeon though. What else? What's it caused by? It's caused by cryptococcus, starts with an N, Neoformans,
Yeah.
or it starts with a G. Gotti, Cryptococcus neoformans, Cryptococcus gotti. Which one is an immunocompetent patient?
Gotti.
Gotti. Neoformans,
Immunocompetent.
most common cause of fungal
Fungal
meningitis, yes. So you see cryptococcus, you see HIV, fungal meningitis, cryptococcus. Okay. The candidiasis. Recurrent candidiasis, recurrent thrush, what are you thinking?
Diabetes.
Very good. And common treatment for dermatophytes. Very good. So that's our gist. I want you to start thinking about hallmarks, what makes these things stand out, because that's what you're gonna see. So we're gonna practice with a few questions. There are resources at the bottom of this one too. Candida auris, candidal endocarditis. It's a bunch of different things that I didn't think you absolutely need to know at this point. Really know that. So.
And don't give honey. When I see them. I see that. Yeah.
Which one do we find with the India issue things?
Cryptococcus.
Which one?
Cryptococcus. Yeah. Cryptococcus. Memorization gal. I was like, I think we're right.
Oh, you are.
Oh, okay. No, you're fine. Actually, no,
This
we're
time
doubting
we're
ourselves.
unstoppable. I gaslight myself into thinking I know things, so.
Oh,
That's
all the
far
time.
off.
Same.
Which fungal infections are most common in those organ transplant patients?
Candida.
Aspergillosis and histoplasmosis.
Very good. All right, first question. And I pulled some from before as well. 6 days after stepping on a nail, a 24-year-old female presents with pain and paresthesia surrounding the wound. She states it feels like the bottom of her foot is tight, but it does not look swollen. Without treatment, what symptoms would you expect to be next? A, delirium and palpitations. B, jaw and neck stiffness and dysphagia. C, hyporeflexia and loss of muscle tone. D, purulent discharge. Or E, severe headache and blurry vision. What do we think that it is first?
Tetanus.
Tetanus, yeah. So what do we remember about tetanus? Usually a wound of some sort, cut of some sort, and then they have what? What do we also call tetanus?
Lockjaw.
Lockjaw. Yes. So we're looking at those. What do we think is the next thing to develop? Because do patients this possibly have, delirium? No, I don't know. Do they? Do they have hyporeflexia? Hyperreflexia. So what's next? A, B, C, D, or E? What's next happening next? B. B, good. They are going to have jaw and neck stiffness and dysphagia. And are they in a coma or are they aware throughout?
They're
Aware throughout.
Very good. All right. Several customers who purchased home canned vegetables at the local farmers market. What was the likely initial manifestation of symptoms? A, diplopia. B, impaired extraocular muscles. C, dry mouth. D, dysphonia, or E, dyspnea. A, B, C, D.
On me.
What is the most likely initial manifestation of symptoms? So we know that it's botulism. Home canned vegetables. What else can, be associated with that? What other foods?
Honey.
Honey. What type of meat? Smoked meats. Yeah. So what do we think's next? Or what was the first symptom? I hear B. What else?
Yeah, because you're gonna reach the
Consensus?
cranial nerve pulses
Is it
first,
B?
and then it's a descending.
B? Right, going with B?
I just compared it to GBS, which is ascending.
It's actually A.
That's what I was worried about.
12 to
Is it
36 hours
A
after they ingest that
first?
toxin,
Is
so
first.
visual disturbance will start. Now, they have a variety of eye changes, but double vision and blurred vision are very common. Was this a descending or an ascending flaccid paralysis?
Descending.
Descending. What did we compare that to that's ascending?
GBS.
Yeah, right. What management strategy is typically considered first for fungal sinusitis? A,
Actually, that's not true.
antifungal. B, surgery. C, topical nasal steroids. Or D, nasal
Or that's
saltwater water. Typically considered first for fungal sinusitis. I'm gonna put these on your board, on your thing too. I'll give you all. A, B, C, or D? Remember that picture of that big aspergilloma in that sinus cavity? What do we have to do to get rid of that?
Surgery.
So the answer is B, surgery. Now, would you do some of these other things? Absolutely. But the first treatment, the first line, the first management strategy is surgery for those patients. Which of the following statements about treatment of thrush is accurate? A, in older children and adults, antifungal medications for thrush should be swished around the oral cavity and then immediately spit out. B, resistance to nystatin is common. C, the best time to administer medication is immediately before meals. Or D, the treatment of choice for thrush is fluconazole or oral nystatin suspension, although numerous antifungal agents are effective. So this is pulling from Dr. Noel's lectures. What is it? D, is that the consensus? That is true, D. You wanna be able to keep that, when you do swish and swallow, you tell patients, put it in your mouth, swish it around, hold it as long as possible, hold it, hold it, hold it, hold it, hold it, then spit. You don't wanna do it before a meal, because why? No, either way, you want it to stay, you want it to contact that mucosa as long as possible. Resistance to nystatin is common, that's false. It's actually pretty rare. All right, long one. 45-year-old man is brought to the emergency department due to confusion and altered mental status. His friend who brought him in states that the patient has been complaining of fevers accompanied by malaise for the past 2 weeks. The patient is currently living in a homeless shelter, but oftentimes he is seen sleeping on the streets by his friends. Medical history is unknown, but a month ago, the patient was hospitalized for pneumocystis jirovecii, formerly pneumocystis carinii pneumonia. Temperature is 38.5 degrees Celsius or 1.3, pulse 80 per minute, and blood pressure is 135/85. On physical examination, the patient is lethargic and mildly confused. Neck is supple, and there are no focal signs. The patient's arms show multiple needle marks. The pathogen most likely responsible for this patient's condition is most likely to show which of the following on further tests. So we're gonna look at the last question. The pathogen most likely responsible for this patient's condition is most likely to show which of the following on further testing. So what are some of the keys of this? He's on the streets. He's been injecting drugs. He was already hospitalized for pneumocystis jirovecii. He has had 2 weeks of malaise, fever. He's confused, altered mental status. His neck is supple. So what are we thinking? Let's look at the microbiology and see what our options are. A, septate hyphae branching at acute angles. B, gram-positive lancet-shaped diplococci. C, forms germ tubes at hot temperatures. D, non-septate hyphae branching at wide angles. Or E, budding encapsulated yeast. So, based on our lecture today, we can already cancel out C, because have I talked about germ tubes?
No.
No. We talked about septate hyphae. Yes, but there's 2 options there. There's septate hyphae at an acute angle and non-septate hyphae branching at a wide angle. Gram-positive lancet-shaped diplococci. Have you talked much about bacteria today? Nope. And then we have the budding encapsulated yeast. Now, 2 of these findings are related to fungal infections. So what are we thinking this is? What shows an encapsulated yeast? Streptococcus, and how do we test that? CSF, and what is the technique called? India ink. India ink is gonna show a halo, and it's gonna show a budding yeast. So the answer is E. E, budding encapsulated yeast. What shows septate hyphae at an acute angle? Aspergillosis. Very good. All right. A 48-year-old man comes to a clinic complaining of fever, chill, headaches, and cough over the past several weeks. A chest X-ray shows enlarged hilar lymph nodes with focal infiltrates bilaterally. A lymph node biopsy reveals macrophages filled with yeast cells that bud from a narrow base. To which of the following locations has this patient most likely traveled? What can you tell me about the possible diagnosis based on just the stem alone? Infiltrates should be a keyword. macrophage is filled with budding yeast cells. We talked about something that the spore is engulfed by the macrophages in the lungs, and then it proliferates to this hematogenous spread. Does anybody know what the diagnosis is?
Histoplasma.
Histoplasmosis? That sounds good to me. So we'll look at our options. Where has he most likely traveled? A, wooded areas in the northeast United States. B, caves in the Ohio River Valley. C, deserts in southwestern United States. D, South America. Or E, the Great Lakes region of the United States. What is our answer? Everybody should know this. B, caves in the Ohio River Valley. Very good. All right. We have a patient who had a kidney transplant. Ding, 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 ding. Kidney transplant 6 months ago. When you see that and you know what we're talking about today, you should already have 3 things in your mind. He's presented to his physician's office with a history of fever, chest pain, cough, and hemoptysis. A biopsy of the lung shows septate hyphae with acute angle branching. The patient has been on several immunosuppressants following the surgery. Which of the following pathogens is most likely to cause this patient's condition? A, Aspergillus fumigatus with a big S. B, Candida albicans, Actinomyces, Pneumocystis jirovecii, or Mycobacterium tuberculosis. A, very good, Aspergillus fumigatus. Septate hyphae with acute branching, acute angle branching. All right. So we have a 45-year-old woman. She presents to the clinic for a non-productive cough of 2 weeks. She has been feeling increasingly fatigued, weak, and has had low-grade fevers. She reports that she also has shortness of breath with any physical exertion. What is the bing, bing, binging in your mind right now? She reports that she also has shortness of breath with any physical exertion. She smokes 2 cigarettes a day. She has had 10 different sexual partners in the past month and does not use protection reliably. She has a past medical history of diabetes. What's that already putting her at a risk of? She's immunocompromised. And she reports that something bad was found on my labs a year ago, but she never followed up because she's been feeling fine. On physical exam, she has diffuse crackles in the lungs. Only one we talked about today had crackles, bibasilar crackles. Upon review of her chart, she had a positive HIV test a year ago. She has started on empiric treatment. So 1, I want you to think about your suspected diagnosis. 2, think of at least 2 differentials. 3, what would be a characteristic imaging finding? Next, if the culture was obtained, what would it show? And lastly, the treatment. So we're gonna take a few minutes. You're gonna give all your answers together. We're gonna answer, and then we have for exactly what. Pneumocystis, jirovecii pneumonia, or PCP. Whether it's classification. All right, that's our suspected diagnosis. Of the ones we talked about today, which ones have high risk for HIV patients? All of them, right? But which one would cause the symptoms of dyspnea on exertion, a fever, that we know is PCP? The bibasilar crackles are PCP. The differential, at least 2. Can you all name some? COVID.
Why not?
Tuberculosis.
Atypical pneumonia.
Chlamydia.
Anybody know any of the other ones with ground glass opacity?
Oh, there's something in
Like
the
sarcoid, or TB? So there's more CMV. Not that are ground glass, but should be in your differential. What is the characteristic imaging finding?
Ground glass.
Yeah. All right, and if a culture was obtained, what would it show?
You can't culture it.
Cannot culture, good. What is our treatment for PCP? Our fungal.
Background.
Background, why? Because it does not respond well to antifungal. If it's an HIV patient, which she is, and we are just seeing her, what else will we give her?
Prophylaxis.
You'll give her prophylaxis, but what do we say works with, if you give it within 72 hours?
Oh,
corticosteroids.
steroids.
Corticosteroids, very good. All right. All right, so again, I want you to just take a look at your slides and really just try to figure out the hallmarks of these, including location, whether endemic, bird and bat versus pigeon, HIV patients, organ transplants, treatments, microscopy, chest x-ray, all of these things to help you when you're differentiating these. You are going to see these on your pants. They are going to certainly be on your pants in one form or another, whether it's how do you diagnose, what is the first line treatment, what is the suspected diagnosis, they are going to be on there. So definitely try to some way organize this information in your brain so that it makes sense. That every time I think of Cryptococcus, I know that it's an encapsulated budding yeast, that it's India ink, whatever you need to do to kind of organize this in your mind, because you will see this again. We are going to, I'm gonna finish early, but you're not gonna leave. I want you to work on your questions for your ID assignment, if you haven't already, for about 15 minutes, and then we'll leave early. I'm gonna pass around a card for Barbara Grimm over at the Proton Center. We're gonna give to her, so if every